And is that going to be like way over here medial, or is it going to be more over here lateral? Or do you remember? It's going to be more a little bit lateral. Is that going to be way over here? What's way over here? The median nerve. That's where the lacertus fibrosus is. So remember we said originally the median nerve was lateral to the what? Axillary and then the brachial artery as well. Okay, but now once it gets down here, it flip-flops. It's going to be on the other side. So now it's going to be medial to it. So that's why if you have compression of that lacertus way medial here, it can cause a problem because the nerve flip-flops its relation to the brachial artery. Okay, so that's the first thing. Everybody okay with that? Okay. The second thing is, this is just kind of an FYI. Okay. So what did I say the anterior interosseous nerve is? Motor or sensory? Motor only. But when we say sensory, what have we kind of narrowed our sensory to? Sensory of what? Skin. Okay. But there's also sensory to joints like capsule and bones and ligaments, right? So sometimes you can get, you say, like a nerve like the anterior osseous, and you say, wait, it has sensory to the wrist joint? And people get confused that way. So that can happen. It's just an FYI. You don't have to worry too much about that. But we'll keep our focus on the skin for now. But just realize there's sensory also in joints, in the capsule, in the bones, in the ligaments, right? And there's pain fibers in there, right? And proprioception in there, and so forth. Other types of sensory like that. So it's just more of an FYI than anything. But just realize in this course, we really confined our talking of sensory to the skin. And you get in deeper other classes down the road, like orthopedics, then you can get a little deeper into getting in the joint. So I'm not trying to teach you everything all 3 years in one semester. Okay, we do save things for other classes. Okay, just be aware of that. Okay, very good. Now, Miss Lindsay, let's put your arm right back up on here. Can everybody see? Okay, good, good. Okay, now, ulnar nerve, ulnar side, right? That's how you kind of remember it. Think of the ulnar nerve, it's on the ulnar side. So it's way medial, way over here. Okay, now, let's back up. What's the origin of it again? Brachial plexus, but keep going. Anterior division of the lower, right? Which is CAT1. Okay? And ultimately, that's going to form the what? The anterior division of the lower trunk forms the medial cord. Good. Okay. So, you can think of the origin, you go back as far as you want to go, but it's sometimes good to be able to get all the way back to the brachial plexus and then go forward. Why? Because if you just start at the median cord and you notice a continuation, you say, okay, what fibers is it carrying? You don't know. So that's why it's important to be able to trace back. And now you know, oh, yeah, I see its relationship now. It's the anterior division of the lower trunk at CAT1, and that forms the medial cord. And that is, the ulnar nerve is the terminal branch, so it's the direct continuation of the medial cord, right? CAT1. All right. Nothing's ever that easy, but, somehow, like when you talk about the ulnar nerve, C7 somehow, some way, finds its way there to produce enough contribution that most anatomists and researchers say you can't just discount it in that counting. Remember, sometimes we do that, like with the median nerve. We say, let's not even worry about C5, it's such a minuscule amount. You can't really do that with the ulnar nerve. So what's the ulnar nerve carrying? C7, C8, T1. Now, still, it's mainly going to be C8, T1, mainly. Okay, but you can't discount the C7, it's significant enough. Okay, so when we get to, okay, so let's back up. So we're way up here again. Okay, all these nerves, you can see it now. We're going down below the clavicle, below the pec minor, and then it's, again, going to travel in relationship to the axillary artery. Where were the median nerve traveling? More lateral, so this is more medial. You can say posterior medial, technically, but it's more medial anyway. Okay, so it's going down medial, and then about, let's say midway down the arm, it's gonna, remember, it's starting kind of anterior, but it's gonna end up posterior because it's gonna go way posterior over here in the cubital tunnel. Okay, how does it get there? It has to go through a medial intermuscular septum, which divides the anterior muscles from the posterior muscles of the arm, from the arm. So what's it going to go through from anterior to posterior through the what? Medial intermuscular septum. It goes through there. Potential source of impingement, but not very common. Okay, then almost right away, there's the medial triceps fibers that kind of branch off of that intermuscular septum, and that forms an arch or an arcade. Okay, there's another arcade, sometimes referred to as the arcade of Struthers. So that's another potential site of impingement. Okay, so we're about midway down at this point, right? And are we anterior, posterior? We're posterior. Okay, then it's going to travel posterior, feel your medial epicondyle on yourself, and feel your olecranon on yourself. Can you feel that? There's a ligament there called Osborne's ligament, and that's one name. Another name is the cubital retinaculum. What's it called?
Cubital retinaculum.
I think the cubital retinaculum is probably the more common name than the Osborne ligament, but they're used interchangeably anyway. Okay? So the cubital retinaculum is going from where? Medial epicondyle to the olecranon. Feel that. Trace it on yourself. You feel it? Okay. Keep feeling it, and then bend your elbow as you're feeling it. Does it feel like it's getting looser or tighter? Tighter. Now, Rob went over this, right? When you flex your elbow like this, that becomes tighter. Okay? And, well, I guess Rob went over more the ligament, the UCL, but same thing. It's becoming tighter, and then if you go into a little bit of valgus, it becomes tighter yet. What are you doing to the cubital tunnel? You're flattening it out. You're decreasing the opening. And what's traveling through it? The ulnar nerve. So that's the source of impingement of the ulnar nerve. Everybody follow that okay? Okay. That's the source of impingement. And it's fairly superficial. If you go right posterior from the medial epicondyle, you kind of roll, be gentle, you roll your finger back and forth, you can pretty much feel the nerve. And of course, all of us, multiple times in our life, have, and it's not fun when we do it, but we somehow hit something going back, right? And we hit, what do we call that? We hit our funny bone, right? And then it zings, zinging pain down your medial forearm into your hand. Okay, what part of your hand? Medial hand. Okay, now we're not really getting to the hand. We're just like the median nerve. We stopped where? At the wrist. Okay, it's going to go into the hand, and so is the ulnar nerve, but we're not there yet. So we're going to stop at the wrist. Okay. Now before we stop, we're not at the wrist yet. So where are we at? It's going through what? Cubital tunnel. And that's the most common source of ulnar nerve impingement, period. Okay? There's another tunnel that goes through our canal, but it's the most common source. And we certainly see it in our overhead throwing athletes due to that flexion and valgus that they go into. It flattens it out, and it can impinge on the nerve. Okay, it's going to travel through there, and then it's going to go, okay, follow this now. Where's it going? It's going over here. What's over here? Rob just went over it with you. There's a muscle way over here. Your most medial muscle in the anterior compartment is your flexor carpi ulnaris, okay? And how many heads are there? 2. Remember, all these nerves go through 2 heads. Okay, there's one on the medial epicondyle, there's one on the, where? Olecranon. So if you feel those 2 bones again, that's kind of where the 2 heads are. Oh yeah, that's where the nerve's going too, isn't it? Isn't that where the nerve's going? Yeah, it's going through the cubital tunnel. And then that's where the 2 heads of the flexor carpi ulnaris is, so it goes through those 2 heads. Another source of impingement, whenever it goes through 2 heads of a muscle, it can potentially be compressed. Okay, so it's going to travel down between the flexor carpi ulnaris and a muscle just lateral to it, and that's going to be the medial half of the flexor decorum profundus. Okay, so it gets half of that. Remember what gets the other half? Yeah, be more specific. interosseous. Okay, good. Okay, yeah. Okay, so that's how many muscles does the ulnar nerve get in the forearm? 1.5, and that's it. Now we're not quite done though, because remember we're dealing with the forearm. So I'm just going to say this in passing. You don't have to worry too much about it right now, but I want you to at least be aware of it and kind of trace it down to a degree. But somewhere in the middle third, there's going to be a sensory nerve that comes off it, and it's called the palmar cutaneous. And this destination is down here in the proximal hypothenar region. See where I'm pointing? Can you see it? Okay, now this is the hand, so that's why I'm not going to dwell on this too much. But I'm just saying it originates here. But where's it going? Down here. Okay, then in the distal third of the forearm, since we're covering the forearm today, right? That's the only reason I'm mentioning these. Another one comes off, but instead of the palmar cutaneous, it's the dorsal. Where do you think it's going? To the back. Okay, it's going back. And we're on the medial side. 1.5 fingers in the medial hand. And again, don't worry too much about that quite yet on the exact things in the hand, because we haven't quite got there. We're working our way there, okay? So how many muscles total motor-wise? 1.5 in the forearm. Sensory-wise in the forearm? In the forearm. Nothing. All the sensories in the hand, but the nerves come off in the forearm, so that's the only reason I mentioned it. At least kind of practice when you're practicing today, at least practice that way too, that it's coming off and you know it's going to go into the hand. Whether you know the exact place it's going in the hand, we don't need to, do the best you can. But basically the big picture is 1.5 fingers is ulnar nerve on the medial side. What's left on the lateral side? 1.5 fingers. 3.5 fingers. Okay. 1.5 fingers, 3.5 fingers. So if this is 1.5 fingers, the median nerve must be the lateral 3.5 fingers. And then the palm as well. So that's how you can break down the ulnar nerve, medial 1.5 fingers and medial palm, and median nerve, lateral 3.5 fingers, that's what's left, and the lateral palm. That's how you break it down. Now it gets a little more complex than that. It wraps around the median nerve, but we're not going to go into every detail of the hand today. Just trying to give you a big picture stuff. Okay? Everybody okay with that? Okay, so I think we're done with the ulnar nerve. That shouldn't take you too long to do. Let me just think for a second and see if I missed anything I wasn't talking about. No. Okay, got it.